Welcome to Managing Acute Dental Pain in an Opioid-Averse Environment. My name is Brian Oglander and I'm with Southwest Oral Surgery. Today we're going to focus on utilizing the non-steroidal anti-inflammatory medications, which are great medications to manage dental pain. We're going to talk about how they work, how to correctly use them, and why they work so well for our type of discomfort that we are trying to manage. There are four pillars for successful pain regulation in dentistry. These include utilization of non-steroidal anti-inflammatory medications, and that's going to be the focus of the presentation we're with today. In the future, we'll talk about utilizing opioids for discomfort. We do want to make sure that we are prescribing whatever medication in an appropriate dosage and frequency, and make sure that we are selecting the appropriate drug regimen based on the type of pain we are trying to manage. Analgesics are classified as opioids and non-opioids. Formerly, it was believed that opioids acted only within the brain and spinal cord, and that non-opioids were confined to action only at the periphery or site of injury. This explanation is no longer valuable. However, both are known to act both centrally and peripherally. In fact, the feature that best distinguishes these analgesic classes is their mechanism of action. Opioids activate specific receptors in a manner identical to opiates, such as morphine, and non-opioids interrupt prostaglandin synthesis, thereby resembling aspirin in action. Non-steroidal anti-inflammatory medications, or NSAIDs, such as ibuprofen and naproxen, have excellent properties for dental implications. They are antipyretic or fever reducers. They are great anti-inflammatory medications if given in appropriate amounts. And they are excellent pain relievers, as we will see later in this presentation. Non-steroidal anti-inflammatory medications are particularly effective when managing musculoskeletal pain, such as third molar surgery and periodontal surgeries. Unfortunately, the efficacy of these agents is typically underestimated, and often narcotics are used in lieu of these non-steroidal anti-inflammatories. This figure reviews the synthesis and function of prostanoids. These are the mediators that are blocked by non-steroidal anti-inflammatories. So if anything, it disrupts the cell membrane. That can be a diverse amount of endogenous or exogenous stimuli. This triggers activity of phospholipase A2, releasing arachidonic acid from the phospholipids making up the cell membrane. There are two families of cyclooxygenases, COX-1 and COX-2. These convert this fatty acid to a variety of so-called prostanoids that are unique to the particular cell or tissue, and these include prostaglandins, thromboxanes, and prostacyclin. Each of these prostanoids has specific physiologic functions, some of which are listed in the table in this figure. Most nonsteroidal anti-inflammatory drugs, your NSAIDs, are non-selective and inhibit both COX-1 and COX-2. Celebrex is a representative agent that selectively inhibits COX-2. It reduces pain and inflammation with little or no influence on gastric mucosa. However, this selective inhibition may promote some greater synthesis of prostanoids derived from COX-1, including thromboxane-mediated effects leading to possible thrombotic events, i.e. myocardial infarction and stroke. Arachidonic acid is also a substrate for lipooxygenase that catalyzes the formation of leukotrienes, and we'll discuss that in a slide a little bit later. This table illustrates some of the most common nonsteroidal anti-inflammatory medications utilized. It also includes their dosage. TID stands for 3 times a day, QID stands for 4 times a day. You'll notice some of these medications are utilized simply once or twice a day. Majority of these medications are non-selective in that they would inhibit both COX-1 and COX-2. Celebrex is a selective COX-2 inhibitor, and its dosage is included. Analgesic efficacy. This graph illustrates a typical dose-response curve for orally administered analgesics. The dose-response curve for opioids, such as morphine, demonstrates an unlimited efficacy in which greater doses provide greater analgesia. At equipotent doses, all opioids demonstrate a similar dose response. In contrast, non-opioids demonstrate a ceiling effect that generally is adequate for relief of mild to moderate pain. For ibuprofen, doses greater than 400 milligrams do not provide further analgesia. For aspirin and acetaminophen, the ceiling effect is achieved at 1,000 milligrams and is somewhat lower than that provided by nonsteroidal anti-inflammatory drugs. The most frequent side effects from nonsteroidals are related to their gastrointestinal toxicity. Prostaglandins stimulate the production of mucus lining that protects the stomach and small intestine, and the erosive and ulcerative side effects common to nonsteroidals are attributed to their inhibiting the synthesis of these particular prostaglandins. This action not only occurs locally when you ingest the medication, but also in the gastromucosa following absorption and systemic distribution to the GI mucosa. It's important to distinguish dyspepsia, or an upset stomach, from GI toxicity. This reflects actual mucosal damage. The incidence of dyspepsia attributed to nonsteroidal anti-inflammatory medications does not correlate with mucosal injury. Although less likely to produce gastric upset, buffered aspirin carries a similar risk for mucosal damage as a regular aspirin. The ability of nonsteroidal anti-inflammatories to inhibit cyclooxygenases in platelets reduces the synthesis of thromboxane A2, which normally contributes to platelet aggregation. This accounts for the so-called antiplatelet effect of NSAIDs and is a consideration following surgical procedures. However, aspirin is the only NSAID that has proven effective in preventing thrombotic events such as acute coronary syndromes or stroke. This is so because the antiplatelet action of aspirin is irreversible, lasting the lifespan of the platelet, about 10 to 14 days. Other nonsteroidal anti-inflammatories bind weakly and reversibly to platelet cyclooxygenases, which results in loss of their mild antiplatelet influence after the drug is eliminated. Although non-aspirin NSAIDs all prolong bleeding time to some degree, this does not correlate with significant clinical bleeding following minor surgical procedures. However, non-aspirin NSAIDs generally are withheld before major thoracic, abdominal, or orthopedic procedures. What NSAIDs do is increase the risk for GI bleeding twofold to threefold in patients either on Plavix or potentially on warfarin. This is due to their effect in diminishing of the GI protective mucosa. So patients who are on NSAIDs have a greater risk for mucosal injury of their intestinal tract or their stomach, and therefore, if they have any type of ulceration or bleeding, if they're on aspirin, that will potentiate that even more. Prostaglandins play an essential role in renal perfusion, and diminished levels of these are believed to account for reported cases of nephrotoxicity after long-term NSAID use. In the healthy patient, nephrotoxicity attributed to NSAIDs requires high doses for extended periods, almost a year or longer. However, a patient with compromised renal function relies more heavily on prostaglandins for adequate function, and acute renal failure can occur within 24 hours of NSAID administration. NSAIDs must never be prescribed for patients who have known or questionable renal function. The ability of NSAIDs to alter renal function has resulted in concern regarding their long-term use in patients with hypertension and heart failure. Although renal function accompanies the pathogenesis of these disorders, and any further renal decline may exacerbate their condition, This condition has not been found to be relevant with short-term NSAID use, roughly about 5 to 7 days. Prostaglandins also maintain the patency of the ductus arteriosus during fetal development. This is a blood vessel in the developing fetus that allows blood from the right ventricle to bypass the fetus's fluid-filled, non-functioning lungs. Therefore, blood can pass from the right ventricle straight to the fetus's organs to provide oxygen. NSAIDs shunt the arachidonic pathway towards leukotriene synthesis. Leukotrienes mediate many of the symptoms associated with bronchospasm and anaphylaxis. They may also result in signs and symptoms of an allergic reaction, such as erythema and redness and swelling, much like you see in the individual in this picture. If we go back to our diagram showing how arachidonic acid is broken down by cyclooxygenases to COX-1 and COX-2 and their subsequent mediators and effects, we see that if we block cyclooxygenase, the balance is tipped towards lipooxygenases and subsequently leukotriene synthesis. The leukotrienes that are developed may be associated with anaphylactoid syndromes. Certain individuals are extremely sensitive to even subtle elevations in leukotriene synthesis. This can result in, again, signs and symptoms of allergic response. It is recommended that the term aspirin or NSAID intolerance should be used to distinguish this reaction from a true hypersensitivity reaction mediated by the immunoglobulin IgE. Acetaminophen is the conventional alternative for patients reporting an allergic reaction to NSAIDs, unless the patient can identify a particular product that he or she has tolerated without a problem in the past. In general, no convincing evidence indicates that a particular NSAID is more effective or safer than other members of this drug class. Selective COX-2 inhibitors such as Celebrex produce less GI toxicity after short-term use, but this advantage wanes as consumption continues. Nevertheless, patients vary considerably in their clinical response and GI tolerance to a particular agent. Given its unsurpassed efficacy and low side effect profile and cost, ibuprofen is generally a sound initial choice. After prolonged use, NSAIDs may interfere with the effectiveness of most classes of antihypertensive medications. Calcium channel blockers are the notable exception. The precise mechanism for this interaction is unknown, but is believed to be related to the diminished vasodilator actions attributed to prostaglandins. In the rare event that postoperative analgesics must be continued for longer than 5 days, hypertensive patients should return to the office for a blood pressure assessment. If pressure has been elevated more than 10% above baseline, it would be wise to replace the NSAID with acetaminophen. Ibuprofen has also been found to competitively inhibit the antiplatelet influence of aspirin. It is the only NSAID implicated in this interaction. An empiric solution to the problem is predicated on the fact that the antiplatelet influence of low-dose aspirin occurs when it contacts platelets within the hepatic portal system directly after absorption. Simply advise the patient to take daily aspirin upon arising and to delay the first dose of ibuprofen for 1 to 2 hours. By this time, the antiplatelet influence of aspirin will have been established. Recently, concern has been introduced regarding increased risk for GI mucosal injury in patients taking selective serotonin reuptake inhibitors. This risk is most significant after prolonged use of NSAIDs. Caution may be advised during short-term use for patients who have had previous history of mucosal injury as well. Finally, serum levels of lithium and methotrexate are elevated during concurrent consumption of NSAIDs. To prevent toxicity, NSAIDs should be avoided in patients medicated with these agents, particularly those taking high-dose regimens. For our purposes, one of the greatest benefits of nonsteroidal anti-inflammatories is their ability to block the production of prostaglandins, which trigger nociceptive impulses or pain impulses that travel to the brain and wind up in the brain's interpretation of the pain intensity. What this diagram is trying to describe is that it's best to give Motrin prior to our numbing medicine wearing off for any type of procedure that's pain-inducing, such that the prostaglandins do not have a chance to trigger these nociceptive impulses, and therefore the pain intensity is greater. We'll conclude this portion of the presentation with a slide on acetaminophen or Tylenol. Tylenol is an excellent fever reducer and it's an excellent pain reliever. The drug inhibits prostaglandins centrally for its action, but it has little action peripherally in inflamed tissue. It's equivalent to aspirin for pain relief. However, it's hepatotoxic or has liver toxicity issues at doses greater than 200 to 250 milligrams per kilogram in a 24-hour period. So we wouldn't want to exceed more than 4,000 milligrams in any 24-hour period. What is interesting with Tylenol is it is a pain reliever that can act synergistically with nonsteroidal anti-inflammatories, so it would be an excellent addition to, say, Motrin or naproxen to provide a synergistic effect and quite possibly better pain relief as opposed to being taken on its own.